Okay, let's kick off. Good morning, everyone. I'm Laurent Castera. I'm the Secretary General of EASL. It's my pleasure to open this first press conference. First, I want to apologize for keeping you waiting. We slightly changed the agenda as Professor Colombo is also on the postgraduate, and the postgraduate is starting now. We just reshuffle in order to provide a slot for Massimo Colombo, and so that he can answer also your question, because then he will have to go to the plenary session for the postgraduate. We also will take the question after each talk. I think it would make it easier rather than having the presenter at the end. So we have Massimo Colombo, as I mentioned, Greg Dorr, and Richard Moreau. So let's start straight away with Massimo Colombo. And as you probably remember, one of the buzz of the ILC 2016 was these two studies from Spain and Italy that triggered a lot of interest regarding the post-severe management and complications with high rate of HCC recurrence in HCV cirrhotic patients that achieve SVR. And we got much more data, of course, as expected this year. And Professor Massimo Colombo, that does not need any introduction, is a world leader and expert in HCC from Milan, and he will wrap up and give you his perspective regarding the different presentation. Thank you, Massimo.
Okay, thank you so much, Laurent. Good morning, everyone. You are being already introduced to the issue here. With the advent of interferon-free regimens, there have been some data emerging that of an increased rate of occurrence and recurrence of HCC after achieving an SVR in patients with cirrhosis being treated with various regimens of direct antivirals. The general opinion is that we are dealing with a completely different patient population with respect to the previous experience with interferon, more advanced, higher risk of having dormant cancer in their liver, and that suppression, the swift suppression of virus replication might change the inflammation-related mechanism that protect the liver against the onset of these tumor cells that are freed and free of proliferating. But this, of course, is hard to establish on the basis of all these studies that have been designed in a retrospective fashion. Retrospective meaning collecting the data after we have treated the patients, so you are, to some extent, entering also a number of referral biases. Patients were selected not in a way to clearly understand whether the new tumors were the result of this or that interference. Okay, having said that, this is the group from Barcelona, the BCLC group led by Jordi Bruix, Professor Jordi Bruix, who was the first to report an increased rate of tumor recurrence in patients in whom a cancer was either ablated or resected, and that were successfully treated with the DAA. Now he is presenting data that comes from a study done jointly with other groups in Spain. Again, here the issue is a referral bias, because you would need to have a pure population prospective follow-up. You see here the group of patients were treated with different regimens. Most of them had undergone curative treatment for liver cancer. We generally think that if the cancer is either ablated with radiofrequency or resected or transplanted, that has a high chance to be a definite cure compared to palliative treatment based on chemoembolization. As a matter of fact, recurrence takes place in 75% of patients undergoing ablation resection. And here the issue is that apparently in this population where virtually all the patients, you see there, the yellow, got an SVR, the rate of recurrence were still high. Here is the graphs representing what? In the blue is the time, the blue lines are the time between therapy of cancer and the last assessment by radiology of the patient getting a complete radiological response, no viable tumor cells. In the gray boxes, you can see it, is the time window between the last complete response assessment and the start of interferon-free regimens. The yellow boxes or lines, if you wish, is the time window between the starting of the antiviral therapy and the last assessment with a CR, a complete radiological response of the tumor. And the red boxes, you see here and there, some of them, the time between the date of the starting dose of interferon-free regimen and the date of the first detection, of the cancer recurrence. Okay, when they, and then finally, the black boxes is the window between the first radiological tumor recurrence and the date of progression, because in this specific study, they evaluated the rate of recurrence of the tumor plus the clinical aggressiveness of the tumor. So how many patients could be saved undergoing potentially curative therapies. So 31% of these patients had recurrence of the tumor, thus confirming the previous report in Barcelona last year. And here is the median time in a follow-up of approximately 1 year. Here are the interquartile ranges, 8 and 19 months. There has been 31%, 1 out of 3 of the patients that had tumor progression, and 6.5% died of it. The HCC recurrence took place in a median time between 2 and 8 months, average 3.5. And the second recurrence, or if you wish, progression, took place within 6 months. So in the end, either recurrence or progression within the first 6 months of observation after the first recurrence of the tumor was huge, 1 out of 3, 30%, and 1 out of 5 died. So the conclusion is this one. Approximately only 1/3 of the overall population with tumor recurrence following successful Hep C therapy could undergo curative therapy. More than half were only treated with palliation, something that is attenuating the course of the tumor, and 1 out of 6 at the best treatment options in terms of treating fever, pain, or whatever is, but nothing that could influence a patient's survival. The next presentation, any question? You wish to have a question immediately after each, or no, at the end? Cumulative, because they are just talking about the same issues.
Yes, at the end as each.
Okay, the next study is a multi-center study that involves Europe and America, and this is very interesting. So the obvious question that the scientist and the clinician pose is why hepatocellular carcinoma recurs following removal of the virus. So the obvious question that some tumor cells were already there, dormant, and they will become free because we have already explained this, that might occur. But according to other investigators, during 20, 30, 40 years of chronic hepatitis C infections, the human genome undergoes manipulations. And particularly, it's not strictly the DNA that is undergoing manipulation. It's the alkaline proteins that are buffering DNA and protect DNA from other agent manipulation. These special proteins are called histones. So it is a kind of glue that takes together all these long molecules of human DNA to protect them during cell replication. So apparently the virus hits this protein, and by hitting these histone proteins, makes DNA liable to undergo changes, and in the end, since cancer is a genetic disease, is a disorder of the genome organization, the reason why cancer onsets following successful removal of the virus appears to be associated with this. And this has been clearly demonstrated at the bench site in this study. They took infected liver cells and they sterilized with direct antiviral agents, and they could see what happened, and they moved to the human ex vivo, if you wish, experiments, where they could demonstrate that, in fact, there are persistent changes after the cure of the histone that, in the end, help oncogenes, those DNA manipulation that took place during the long period of chronic infection with hepatitis C, to express their full potential carcinogenetic activity. So, according to this study, the reason why the tumor liver cell cancer may develop in patients who have been successfully sterilized with direct antiviral or interferon-based regimens, if you wish, is linked to the manipulation of these histones. That's very interesting. And these are additional data that are, to some extent, against the initial report by the group in Spain. When the report from Barcelona was spread around, there have been flourishing of reports that were published in our journal, Journal of Pathology. Some of them have been already published, others are online, that in the end are to some extent providing contrasting figures. This is a study from the Servier group. It's a large multi-center study done in France that started originally in the era of interferon, then move across the era of direct antiviral. You see more than 1,200 patients from the prospective multicenter INRS Servier cohort. 2/3 of them achieve sustained virological responses, and 179 develop an ACC. Data were scrutinized according to a number of methodological approaches, if you wish, and what it was definitely found that cancer could be predicted by certain patients' characteristics. So following an SVR, following a complete removal of the virus, aged persons, more than 50, those who had a history of alcohol intake, you know, alcohol might be carcinogenic to various organs, including the liver. Low platelets, what does this mean? It means portal hypertension. The bigger the liver, the more inflamed the liver, the bigger the spleen, the lower the number of circulating platelets. And of course, alpha-fetoprotein, which is a peculiar protein because it's physiologic. It is present in the regenerating livers, but it's also, it might also be present in the transforming liver, in cancer livers. Plus GGTP, or gamma-glutamine transpeptidase, which is a marker of liver disease severity, if you wish, or better, of liver inflammation, and also expanding tumors. There's multiple signals. So the conclusion of this author is, look, cancer can develop, but the frequency at which the cancer develops following SVR largely depends on the demographic characteristic of your population. Aged people, those with more advanced liver disease, or more portal hypertension, those with these biological markers of cancer, alpha-feto, are those at increased risk. And you could develop a kind of a tree where you start. If a patient is in SVR, depends on the platelet counts. If the platelet counts are, let's say, very high or higher than 1,000, 100,000, meaning that the liver is not that bad, then you can split the risk in those having alpha-fetoprotein elevated or normal and those having gamma-GGTP elevated or normal. And you see here the curves are a little bit different according to these variables. If your patient has got an SVR, the risk of developing cancer is less. So, going backward, if your patient did not get an SVR and has this variable, here are the increased risk of developing cancer: high, 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 moderately high. If your patient has achieved an SVR, no more virus in the liver and in the blood, of course, then you can split the population according to the age, to the numbers of the platelets here, 85,000, sorry, or the age, 50, we said, and you might have a different risk. The lower the platelets, the greater the risk, and the same is with the age. The higher the age, the higher the risk. So they were able to construct a kind of a tree of an algorithm to identify the higher risk population. The next study is the risk of HCC in patients with SVR, again, this time by a treatment regimen. This is a very interesting study that was done in the setting of the Scotland. And here what they showed that comparing SVR generated with interferon containing an interferon-free regimens were a little bit different from each other. The population was different. Those receiving interferon-free had more advanced liver disease, were aged, worse population compared to, because interferon could only be given to patients with a better liver function compared to interferon-free regimen that can be administered to virtually all pattern of tumors. And when they run the univariable analysis, which picks up just the absolute risk, there was an increased risk for the patients receiving interferon-free regimen to develop cancer occurrence. But when they introduced the multivariable analysis that weights all the variables that can influence this risk, they realized that by aligning the patients for the same degree of liver impairment, age, and comorbidities and cofactors liver cancer, this risk was to some extent nullified and become as low as in, or if you wish, as appreciable as in patients receiving interferon. So, when these differences were adjusted for the risk of HCC occurrence, the HCC occurrence was comparable for interferon-free and interferon-containing regimens. So that is a good news. Next study, again, SVR in patients with an SVR generated by direct antiviral agents. This is an important study because they apparently demonstrate, these studies come from Japan, a well-respected group of investigators, that the risk of developing cancer declines in patients that develop an SVR. So all these studies that we are presented come to the same conclusion. The risk of developing cancer following DAA is the same as the risk generated in patients with interferon regimens, containing regimens, if you are wise enough to align the patients at the starting point of analysis for the risk of developing cancer, which means demography, the age, disease severity, alcohol, obesity, diabetes, all these stories, they are exactly the same. Of course, the risk of developing cancer appears to be linked to some modification of the histones. This has nothing to do with our comment. And this is a study done in Japan where the risk of developing cancer in patients receiving interferon-free and PI, first-generation protease inhibitors like boceprevir, telaprevir, prospect, riba, was found to be exactly the same. Here are the numbers. And when the curves are shown here, you see that these two differences are not statistically significant, 2.3 versus 1.6. Here are the curves. And more data that are to some extent contrasting the original release or report from Barcelona. There was no increase in the occurrence rate of HCC in a Chinese population. Professor George Lau, who was sitting in the back, was the leader of this study in a population treated by DAA compared to interferon following eradication, and this is a long-term follow-up. Of course, this data needs to be weighed with the proper statistical analysis to remove the bias of the patient's referral. Interferon was generally administered to patients that were younger, in a better shape, with the better livers, could tolerate interferon, were keen to collaborate, were adherent here and there, whereas these magic pills can be administered to everyone, so patients' population definitely differ from each other. And here are the results. Compared to interferon, the interferon-free regimen was not a risk factor for HCC, but there were factors that we have already alluded to that at the single patient's level could reach the chance of developing cancer during the follow-up once the virus has been removed. And this is diabetes, because diabetes and the metabolic syndrome, generally speaking, so obesity, dyslipidemia, other factors, are to some extent pro-carcinogenic factors. I mean, we know that these patients are at an increased risk of developing cirrhosis and liver cancer independently on alcohol and virus. Then other risk factors is age, of course. The longer the duration of infection, the higher the risk that the virus can exploit its carcinogenic activity. And in the end, disease severities that can be assessed counting the platelets, like in the previous paper, looking at the synthetic activity of the liver, or using this new methodology. This is a machine. Fibers. Liver stiffness means the hardness of the liver, and can be measured in various ways. Originally, it was measured by a mechanical machine called FiberScan, is a shareware, but here we have the greatest expert, Professor Castera. In other words, the higher the liver stiffness, the more disease is the liver. So this was another predictor of cancer development. And when the patients were aligned for these risk factors, the so-called propensity score analysis. You take a subgroup, the patients that can be compared for the same demography, clinical factors, or comorbidities being or not being present, then the difference were not there. So interferon-based and DAA-based treatment that are the same. And this is on the last paper presented already in Geneva. This is the occurrence of HCC in a large population. Sicily is an island, overcrowded. They made a study that lasted a couple of years. All patients with advanced liver disease were enrolled in this analysis because in Italy we were bound to deliver DAA therapy only to patients with far advanced liver disease. Pre-cirrhotic, cirrhotics, or those with cancer removed through surgery or ablation. And here is the situation. Patients failing to achieve an SVR were at greater risk of developing cancer compared to SVR patients, independently of any variables. But when you scrutinize your patient's population, you realize again that factors associated with an increased disease, liver disease severity were associated with an increased risk of developing cancer, apart from the fact that the greater risk of developing cancer was associated with failing to achieve an SVR. And in that specific study done in Sicily, it was already reported that the risk of developing cancer in SVR patients were as high as the one that was expected in naive patients not being treated, so in the, let's say, viremic patients. And in that specific study, it was also already reported that there was no increased rate of a very aggressive tumor compared to the original report by Spain. So this is to finish my presentation, Mr. Chairman. Yes, going backward. Sorry, ma'am. Oh, apologies. Okay, here we are. Conclusion 1, conclusion 2. But the important message from this study was already delivered, that there is no apparent increase in the rate of occurrence of the tumor in patients with cirrhosis treated with DAA, and the rate of aggressive tumor is as low as in the general population of viremic cirrhotic being screened, being under surveillance. So approximately 11% of those cancer were beyond Milan criteria, and 90% were within Milan criteria. Sorry,
thank you very much, Massimo. This is open to discussion. So basically, most of the studies you have shown, apart from the initial one, are negative, addressing different populations from different countries with different risk factors. So what would be the wrap-up message that you would take from the message is studies?
Okay.
How can you explain the discrepancy? Because the initial study, of course, triggered a lot of interest, and this is what science is all about. A group start publishing challenging results, and then different groups work on the issue and come up with a different result.
Well, I think that we still need to have prospective validation of data, and studies are going forward. Currently, the vast majority of hepatologists in Europe are not taking action. They still treat their patients with advanced liver disease, with DAA, because the clinical benefits associated with an SVR in patients with advanced cirrhosis definitely overrule to some extent the anecdotal risk of developing severe recurrence of HCC here and there. So the general trend is to keep on treating patients with advanced cirrhosis.
Two questions. The first one about the results from Barcelona. I think both studies, also this one was done by Maria Reik.
Yeah.
What we saw today, are these the same patients that were presented at the last EASL meeting, or are these like new incident cases of HCC?
No, that is a new
question.
collection they have started doing, and they pull data from 3 other centers. One is in Valencia, the other one is Bruno Sangro, and I forgot the fourth one. Yeah.
Which would mean they observed the same...
Yeah, they are confirming, exactly confirming the original report. Yeah.
The clinic. Okay.
And currently they are the only one, let's say, in Europe, because the rest of Europe is to some extent contradicting. So yes, we are very much interested in looking at the validation studies following a prospective recruitment that is taking place here, in America, everywhere, as you might predict.
My second question is, this is also the second time I hear that if a tumor reoccurs after DAA therapy, it seems to be more likely aggressive and fast growing. And there was another study presented at AASLD, which basically said the same even in cirrhotic patients without tumor history. If they had a tumor, almost half of them were very aggressive, very fast growing, multiple nodules. So could there be a risk in that subgroup of patients who do develop HCC that somehow, possibly due to a break of immune tolerance, these tumors do grow faster after DAA?
Yeah, the possibility is there, and these data were presented by Professor Alberti in EASL from northern of Italy, but I might tell you, from the same country, Sicily, and northern eastern Italy, we obtained completely different informations. According to Alberti, there is an increased risk of developing clinically aggressive cancer beyond Milano, let's say. And from Sicily, this is not true. So what we really need is carefully conducted prospective studies, because the studies that we are dealing with, most of them are largely biased by problems of patient referrals, because the original design was to assess the antiviral activity of these drugs, not the chemoprophylaxis. I really apologize, but I have to chair the sessions over there, I have to run. Apologies. Thank you. Thank you, Laurent.
Thank you, Massimo. We move to the next presentation by Greg Dorr from Australia. So this is again on the same topic, but this is a meta-analysis.
Thanks very much, Laurent. I'm presenting this abstract on behalf of my co-authors, particularly the lead author, Reem Waziri, who's one of our PhD students. So just in terms of background, I think the first thing to say is that we're not talking about whether DAAs cause liver cancer. We know that eradication of hepatitis C from the body in people with cirrhosis reduces the risk of HCC development. This is a meta-analysis done in the era of interferon-based therapy that showed about a 75% reduction in the risk of HCC following cure in people with cirrhosis. And I think from first principles, I'm an infectious diseases specialist, and I try and sort of bring things back to sort of common sense. How would elimination of a pathogenic virus lead to a deleterious sort of effect in terms of causing a major illness such as HCC? So that's the sort of first principle I look at it. So I find that hard to sort of grasp in an infectious disease sort of sense. But then does interferon provide something that in terms of the interferon effect along with the cure? So are you getting something else apart from clearing the virus from interferon that might protect you or reduce the risk of HCC? So I think the first thing to remember is that we're not talking about whether the antivirals themselves actually cause HCC or increase the risk of HCC. We're talking about whether there's a differential risk following cure between people that have been treated with interferon-based therapies versus people being treated with DAA therapies. So our study aims, because of this sort of controversy in terms of the studies that had previously been presented, were to compare the risk of HCC occurrence following cure with DAA therapy versus interferon-based therapy in patients with Hep C-related cirrhosis. The second aim was to look at the recurrence side of the question, so to compare the risk of HCC recurrence following a cure with DAAs versus interferon-based therapy in patients who'd received curative HCC treatment. So we undertook a large systematic review. As is the case with these systematic reviews, you have to look at thousands and thousands of abstracts and titles of published papers, and that's where my poor PhD students spent many, many hours going through this and working through the systematic review. And then you come down to a relatively small number of studies, because a large number of the studies are not really addressing the question that you've posed. If you look at the excluded studies, a lot of studies didn't involve hepatitis C treatment at all. Other studies, the treatment was there, but it was unclear in terms of the outcomes. Some studies weren't in patients with cirrhosis or didn't define those subpopulations of people with cirrhosis. Some studies there was duplicate populations and unsuitable design. So that's why you're left with a relatively small number of studies, 26 in the occurrence question and 15 in the recurrence question that we looked at. I think the first thing to then compare is a baseline characteristic. So are these populations different? So the populations that we're treating in the interferon era, are they somehow different to the populations we're now treating? And we're talking about people with cirrhosis. We're not talking about people with pre-cirrhosis. So if you look at the HCC occurrence, these are people with cirrhosis. You'll see immediately that the age is different. So there's an 8-year older mean age among those being treated with DA therapy. And you heard from Professor Colombo how important in a number of those studies age was in terms of a factor for risk of HCC, even within people with cirrhosis. You'll also see that the Child-Pugh score, so there was about a third of the patients in the DA era who had Child-Pugh B or C, so not sort of very well compensated liver disease, whereas all the patients who were treated with interferon-based therapies had compensated liver disease because it was harmful, in a sense, potentially harmful to use interferon-based therapies in those people that had more advanced liver disease. And you'll also see that the follow-up was very, very different. So in the DA studies, they only had a median follow-up of 1 year compared to over 5 years for the interferon-based therapy studies. In the HCC recurrence studies, the differences were less marked. That's not surprising in that all these people had HCC. Okay, so their age was pretty similar. But if you look again at the follow-up median time, 1.3 years versus 5 years, very, very different. If you just look then at the meta-analysis results in terms of this is the incidence of HCC in people with cirrhosis, you'll see that the incidence is higher in those in the DEA studies, so 3 per 100 person years, so a 3% annual risk of HCC in those following cure with DA therapy versus just over 1% annual risk for those treated with interferon-based therapy. So you think, wow, what's going on? Is this a 3-fold higher sort of risk of HCC in people with cirrhosis who have a cure? Then looking at the recurrence studies comparing the meta-analysis incidence rates in interferon versus DA, much more similar. So 9% per year in terms of recurrence risk versus 12% per year in the DA studies. First of all, you see how high those risks are. So recurrence following a cure or apparent cure of HCC is pretty common. So that initial study in Spain showing a large number of people developing recurrence of HCC is, in a sense, not that unusual because recurrence is seen very often. And a meta-analysis recently showed that the 2-year recurrence risk was as high as over 40%. So we do often see a HCC recurrence among people who've had potentially curative therapy. What we wanted to do then is look at those sort of key factors that might be influencing these risks. So if you look at the figures on the left, that's looking at HCC occurrence. So you'll see the relationship between follow-up study, so each individual study, the median follow-up, and the incidence of HCC, and then the regression line through those points. And you'll see that as the follow-up period lengthens, the incidence of HCC comes down. Okay. And that's what we call sort of a cohort effect. So often in the early period of follow-up, those people at very high risk develop the event, in this case HCC, and as you extend the follow-up period, the overall group becomes lower at risk. And you get disease regression in people who are cured who have cirrhosis. So that leads to a reduction in risk. So if you're only following people for a relatively short period of time, you can get these apparent higher sort of risk rates coming through. You'll also see the relationship between HCC incidence and age. So as you get older, even within cirrhosis, the risk of HCC goes up. And you can see exactly the same sort of themes coming through on the right in the relationship between follow-up period and HCC incidence in recurrence and average age and HCC recurrence risk. So then what we do is we do unadjusted sort of relative risk comparing interferon treatment to DEA treatment. And you can see for recurrence, the unadjusted relative risk shows that treatment with DEA therapy appears to have a higher risk of HCC, and a trend at least to that for recurrence. But then when you adjust these risks, you can see that it completely changes. So in fact, even though it's not significant, if there's a trend in any direction, it's a trend towards a lower risk. And exactly the same relationship you see with HCC recurrence. So in conclusion, our meta-analysis has found that there's no evidence for a differential HCC occurrence or recurrence risk following a cure from DEA and interferon-based regimens. The high incidence following DEA therapy can be explained by shorter duration follow-up, a so-called cohort effect, and older age of those at baseline, a higher baseline risk, as I said, Professor Colombo also demonstrated. Thanks very much.
Thank you very much. This paper is open to discussion. Please.
Yes, I also had two questions. The first is relatively short. Did this meta-analysis include the studies that Dr. Colombo presented, or are those two new? And the second is, I was a little confused about how the patients are of more advanced disease, because my understanding is with the new DAAs being better tolerated and everything, there's a tendency to give them to more patients without waiting for them to develop advanced disease.
So I'll answer the second question first. So in the DA era, the patients have more advanced disease. So in the interferon era, for people with advanced cirrhosis, what we call, say, decompensated cirrhosis, it was not the usual clinical management to use interferon-based therapies because of the potential toxicity of those therapies in people with liver failure. So now that we have DA therapy, much better tolerated, good outcomes, even in people with decompensated cirrhosis, the spectrum of people with cirrhosis is broader in terms of who we're treating. So once you broaden that spectrum, you're including a group with baseline higher risk of HCC. And the other important thing I didn't mention is that the duration of treatment and to cure is very different now. So in the interferon era, we tended to treat people with cirrhosis for 12 months and then cure was 6 months later. So you've got this 18-month period from baseline to when you can say someone's cured. In the interferon-free era, often people with cirrhosis are only treated for 3 months, some for 6 months, and then the cure is 3 months later. So it's an 18-month to get to cure versus a 6 to 9 month period. And some people can have very small HCC, so even if they've had a pre-treatment ultrasound or other imaging, may have missed that very small HCC. So then 6 months later, it becomes apparent that they've developed HCC. That's not because they were treated with DA therapy, it's just the time course and the progression of the HCC. If that had been in the interferon era, it would have been an on-treatment HCC compared to a post-cure HCC diagnosis. Another sort of reason why there's such a difference in looking at this through the interferon sort of prism versus the DA prism. The first question is no, we haven't included the studies, they weren't available. We had to draw the line at some point. I don't think it's going to change anything. If anything, the studies coming through now are sort of tending more towards showing no differential risk.
But if I may add a comment, I think this is a critical point when trying to understand where the differences come from. I mean, the context, to put in context, the treatment has completely changed because we're not addressing the same population. I think this is critical. Any other comment or question?
And the question is actually answered. It's more of a comment. This is really important to add these explanations because when I first saw a graph showing that within 1 year after DAA, the amount seemed to be much higher than interferon after several years, it looks very alarming on the surface. But I get that there are many more high-risk patients that are now in the SVR cohort that used to be untreatable at the time. And some on-treatment HCCs are now just happening post-treatments because they're so short.
I mean, I'll show the figure this afternoon in the presentation, but we have another figure where we've looked at even the effect of follow-up time within the DAA studies. Now, obviously, they're much shorter overall, but if you just look at the DAA studies, in fact, there's already a trend line to lowering of risk in the longer follow-up period. So again, it just makes that point. It's a classic sort of cohort effect. You get these individuals with very, very high sort of risk and maybe undiagnosed HCC, as I've talked about, sort of coming through and having the event. And as you follow up over time, that the incidence changes. Yeah.
Any more questions?
I'll just ask one more, Simon from MedPage today, just to see if you can make it more explicit. As you start treating more and more people with early and early stages of disease, would you expect to see a more pronounced reduced risk of liver cancer overall?
Look, absolutely. The best HCC prevention strategy and the best way to reduce HCC-related mortality is to scale up DA therapy broadly and as rapidly as you can. And there's absolutely no doubt that that will have an impact on HCC burden. I just want to make a final point in terms of the aggressiveness.
Burden, but not occurrence, because these patients are less at risk of developing HCC if they don't have cirrhosis. I think this is critical. But in terms of burden, I completely agree with you. This will.
But if you stop people progressing to cirrhosis,
of course,
then you reduce the
at-risk
population. Absolutely. I just wanted to mention the aggressiveness sort of side of it. We can't sort of look at the aggressiveness in the meta-analysis that we've done, but one of the really important factors to look at going forward will be survival following HCC, and we'll be looking at that very closely. And I would be very, very surprised if survival following HCC in the DA era is reduced rather than improved. My hypothesis will be that we'll have improved survival following HCC. People are not going to be dying from decompensated cirrhosis. I think the overall risk of recurrence is reduced by both interferon and DAA cure. So I expect to see an improvement in survival and certainly not a reduction in survival as might be suggested by more aggressive HCC cases.
Thank you very much, Dr. Gore. So now we move to the next and last presentation given by Richard Moreau. Richard, please.
So, good morning. Okay, it works. So I will present our trial called a randomized trial of 6 months norfloxacin therapy in patients with CHIPUC class C cirrhosis. And no disclosure. As you know, fluoroquinolones include Norflox and Cipro. However, long-term oral fluoroquinolone therapy to improve outcomes in patients with cirrhosis is a debate. In 2007, Fernandez and colleagues from Barcelona published the results of a randomized double-blind placebo-controlled trial of Norflox in patients with advanced cirrhosis without prior SBP. The co-primary endpoint was survival at 3 months and 1 year. Other endpoints were SBP and hepatorenal syndrome. And as you can see, they found that Norflox increased the probability of survival at 3 months and 1 year. They also found that Norflox was able to reduce the risk of developing SBP. SBP means spontaneous bacterial peritonitis, and hepatorenal syndrome referred to as HRS. However, if you look at the yellow box, you can see that the inclusion criteria are a little bit complex. You can also show that the total number of patients included in this trial is very small, 68, and the p-value for survival at 1 year is only 0.05. Moreover, there are trials using fluoroquinolone therapy which didn't find any reduction in risk of SBP and or death. Moreover, the prolonged use of oral norfloxacin can be associated with the emergence of ESBL-producing gram-negative bacteria, and these bacteria may induce severe infections. Therefore, we aimed to investigate the effects of Norflox administration on survival in a large series of patients with Child-Pugh class C cirrhosis. We conducted a national, multi-center, randomized, double-blind, placebo-controlled trial of norfloxacin. The sponsor was the French government. We enrolled patients with Child-Pugh class C cirrhosis. These patients didn't have HIV, HCC outside Milan, and didn't receive fluoroquinolone within the last month. Patients were randomly assigned to receive either Norflox 400 mg per day or placebo for 6 months. They were seen every month. The outcomes were, for the primary outcome, 6 months mortality. Secondary outcomes included liver transplantation, but also the development of liver-related complications such as kidney dysfunction, encephalopathy, and variceal hemorrhage. Regarding the sample size, assuming 80% power to detect a decrease in 6 months mortality from 40% in the placebo group to 25% in the Norflox group, a two-side type 1 error rate of 0.05, 5% of loss to follow-up, we calculated the sample size of 392 patients. These assumptions were based on the Fernandez trial I mentioned before, and it is important to note that in this trial there was censoring of data following liver transplantation, SBP, and loss to follow-up as of the date of these events. Okay, so we applied for the statistical analysis the intention to treat principle. Regarding the primary outcome, we used the competing risk analysis, and more precisely for estimating the cumulative incidence of death. Liver transplantation was taken into account as a competing risk of death with the use of cumulative incidence curve. These were then compared between groups by means of the gray test, and whereas we used the fine and gray model to estimate the subdistribution hazard ratio. For secondary outcome, we used the traditional Kaplan-Meier model with the censoring of liver transplantation and death. An important point is that in the protocol of the study, we pre-specified that study drug should be discontinued when the patients develop SBP or in case of liver transplantation. What about results? We enrolled, in fact, middle-aged male with alcoholic cirrhosis. 40% of these patients had alcoholic hepatitis histologically proven, and very few patients had prior episode of SBP. These patients had advanced cirrhosis, as indicated by the Child-Pugh score, the MES score. There were very few HCC, and 40% of patients, as expected, received non-selective beta blockers, and 20% received corticosteroids. What about the retention of patients in the study? Here I show 3 columns of the whole population and the 2 study groups. Please read first the whole population. As you can see, we had 3% of loss to follow-up. Interestingly, 55% of patients modified their consent to less than full participation. For example, some patients forgot to take some pills, but it was a transient, and or missed the visit. And 42 patients finally had full participation at last visit. These findings illustrate the challenges of performing interventional trial in this population of patients with advanced alcoholic cirrhosis, and these findings had already been observed in other trials. Let's look at the treatment discontinuation. Here you have the 3 columns. You can see that overall the study treatment was discontinued in 46% of the patients, but if you look at the reason for discontinuation, you can see that death was a major reason, but also pre-specified reasons indicated in the protocol were present, for example, discontinuation for SBP and liver transplantation. And there were only 12% of patients who withdrew their consent to participate in the study. And if you look at the 2 groups, you can see that the rate of discontinuation was a little bit higher in the placebo group, and this was due to higher rate of death, 18 versus 12, and higher rate of SBP, 12 versus 7. Okay, let's look at the primary endpoint. As you can see, the cumulative incidence of death was significantly lower in the norfloxacin group as compared to the placebo group. And if you look at the sub-distribution hazard ratio, you can see that unadjusted or adjusted for a non-selective beta blocker and corticosteroids, the p-value and the interval, the confidence interval are significant. Okay, so norfloxacin decreased mortality. Let's look at infection now. SBP first. The cumulative incidence of SBP was lower in the norfloxacin group as compared to the placebo group, but it didn't reach the statistical significance. In contrast, the cumulative incidence of any infection or gram-negative infection was significantly lower in the placebo group, in the norfloxacin group compared to the placebo group. For gram-positive infection, there was a trend for lower cumulative incidence in the norflox group, and interestingly, the cumulative incidence of septic shock was similar in the 2 groups. Let's look at the other secondary outcomes at 6 months. The cumulative incidence of transplantation was similar in the 2 groups. Regarding liver-related complications such as kidney dysfunction, encephalopathy, or varicose hemorrhage, there was no between group difference. And therefore, we do not confirm previous trial showing that, for example, Norflox reduce the risk of kidney dysfunction. The strength of our trial is the multi-center and double-blind design. The fact that liver transplantation was taken into account as competing risk. This is a very important point. Of course, our trial has limitations. We enrolled 291 patients rather than the projected 392. This was probably the results of a combination of slow recruitment, probably related to a loss of equipoise in view of various guidelines recommending open-label Norflox use. Also, termination of funding, time expiry of the trial drug. However, I must say that the use of competitive risk, competing risk analysis may require a smaller sample size than the traditional Kaplan-Meier method. So in conclusion, ladies and gentlemen, in this trial involving patients with Child-Pugh class C cirrhosis without recent history of fluoroquinolone therapy, 6 months mortality was significantly lower among patients who received Norflox than among those who received placebo. Norflox also reduced the risk of infection, but not that of SBP, and had no effect on the development of any other liver-related complication. Thank you.
Thank you, Dr. Morrow. This paper is now open to discussion. Please.
Yes, sir.
Yeah, Michael Smith, MedPage Today. What's the clinical picture now? What are doctors doing with these patients? Are they giving them Norfloxacin? You seem to imply that that was the case, that the study's in a sense overtaken by what doctors are actually doing. And does this support that, or it seems to support it, but what's going on?
I think that this study, when it will be published as a full paper, will change the patient management and patient care. And I think that patients with Child-Pugh class C cirrhosis who are admitted to the hospital will receive Norflox. And it is reasonable to recommend Norflox because we found a significant effect on mortality, of course. And interestingly, we didn't find any emergence of multi-resistant bacteria because we were a little bit concerned by the emergence of this bacteria, and it didn't occur. So I think it is reasonable to recommend the use of the Norflox.
What's the current practice?
The current practice is we don't know. You know, there are studies which support the use of Norflox, but these studies are small studies and studies showing that there is no effect. Therefore, we were in between. And this trial, I think, will answer the question.
Risha, if I may challenge you, you mentioned that this might change the practice, even though if we, if you look at your results, the mortality at 12 months is not different. It's different at 6 months, but not at 12 months.
Yes, but the mortality at 6 months is significantly decreased.
Yeah.
Yes.
But not at 12 months.
But that, maybe I was not sufficiently clear. The trial was divided into 2 periods: double-blind treatment period and double-blind post-treatment period. In other words, patients were followed up for 6 more months, and 12 months mortality reflects the 6 months treatment and the 6 months post-treatment. Therefore, probably the effects of the antibiotics do not persist during time when you stop the antibiotic.
And 6 months was the primary endpoint. I think
Yes.
this is critical
Yes.
also. This
Yes.
is very important to
Yes, yes. Maybe I
understand.
was not sufficiently clear.
Yeah, I think this is critical because
Yeah.
I agree it likely will change
Yes.
the practice in the
It
end.
was not a 12 months trial of norfloxacin use.
It was 6 months.
Yes.
Please.
So does that mean then that you should not stop the patients, maybe 6 months they can
Yes,
go
yes.
indefinitely?
Yes. This is an important point because if you look, I didn't show these results, but we found that the beneficial effect on infection persisted during time. Therefore, probably there are some long-term effect, at least on infection, not on survival, but at least on infection. And this suggests that the treatment should be pursued.
Please.
To follow up my colleague's question, do you plan any 12-month trials? And do you predict there may be an additional risk of gram-producing bacteria if it's prolonged?
Yes. The ideal trial should be 12 months. I agree. And we have always the same concern regarding the emergence of multi-resistant bacteria. But I don't know if you attend to the CITES Club meeting yesterday, and it was very interesting because they produced a map of bacterial infection throughout the world. And they showed that the epidemic, the emergence of ESBL-producing bacteria is nil, and no relationship with the use of quinolone in this patient. Therefore, probably it's a myth.
Any other questions? If not, thank you very much, Dr. Moreau again. I hope this met your expectation and we were able to answer all your questions. Thank you very much again.